Welcome to today's episode of the One is Enough NKR podcast. My name is Samantha Hil, and I am the marketing director here at the NKR, as well as a living kidney donor recipient.
And my name is Michael Lollo. I'm the Chief Strategy Officer and a living kidney donor.
And today we are talking about what, Mike?
Well, this is a topic that is not so familiar to me. Although I do have 3 children, I did not get pregnant. My wife did. So this podcast is more geared towards women, I think. But Samantha still wanted me on here. I'm not quite sure why, but I guess we'll figure it out as we go along.
Well, so today we are talking about fertility and pregnancy in transplantation. And so this is something that is very near and dear to my heart because this really impacted me, especially. And when I was transplanted back in the Stone Ages, as I always like to say, the idea of a transplant patient getting pregnant and having a child were just like the most astounding idea in the world. You know, it was not something that you did because of the medication at the time. You know, this was 16 years ago, and the state of the transplant industry. You know, you didn't do that. It was a very, very bad idea. They, in fact, told me, and Mike might want to cut this out because he usually hates it when I say this, but when I was 12 years old, they told me, you know, the worst decision I could ever make would be to get pregnant. And if I ever did, the best thing for me to do would be to terminate the pregnancy. And so, you know, I always grew up thinking, okay, well, that's just never going to happen. So I'll adopt and move on with my life. So in walks, so then, you know, I aged out of the pediatric transplantation system. My nephrologist retired, in fact. My pediatric nephrologist, Valerie Johnson, who was absolutely epic at Cornell, loved her dearly. She retired, and so I needed to find an adult nephrologist. I was 20 at the time. And I bounced around to a couple different centers, a couple different doctors, before finally, full disclosure, ending up with our guest for the day, Dr. Nicole Ali at NYU, who I have loved ever since. And this actually came out of my first interaction with her. So my first appointment with her about 2 summers ago was, you know, just a regular old checkup and a get to know you kind of thing. I mean, my kidney was fine, so there wasn't much we had to do, but we were going through the regular questions of, you know, do you smoke, you know, do you drink, et cetera, the regular normal intake questions for a new patient. And one of those questions was, you know, are you pregnant? Do you plan on becoming pregnant? Because, you know, I'm a female. So it was just normal.
Boy, Dr. Ali got personal right away.
Oh, yeah. Again, just the regular intake questions, right? But, you know, I said, well, wait a minute. Before you leave, what if I had said yes to any of those? And at the time, I was painfully single. So, you know, there was no chance that was actually going to happen, or going to be, you know, said yes to. But, you know, I just wanted to know because it had been 16 years. So maybe there was some change. You know, there had to have been. It was 16 years. And she said, oh, well, sit down because things have changed. And I told her, you know, what I was told is, you know, when I was 12 years old. And she was like, oh, no. Things are very different now. And I'm going to have her actually answer what she said. But that's kind of the basis of why we're doing this episode, because it was so different from what I had been told. And that's part of why we're doing One is Enough, right? To get correct current information out into the world and normalize the conversations around transplantation, both in, you know, the process of donation, but also living your life post-transplant, both as a patient and donor.
So what do you say to all that, Dr. Ali?
Yeah, so I'm going to just go ahead and introduce Dr. Ali from NYU. She is the medical director of the kidney transplant program over there. She's, again, my nephrologist and just one of the best transplant nephrologists on this planet, I think, but I'm incredibly biased. So.
I will second that. She is absolutely amazing.
Yeah, she is also on our medical board and is a great help and friend to the NKR.
So how did you have time to even do this podcast with all that stuff?
That's why we're doing it at this hour.
Yeah, it's 2 a.m. Just, you know, FYI. No, I'm kidding.
Just kidding.
So is there any other title that you want to add?
No, I mean, I'm I love being a transplant nephrologist. I'm the director of outreach for the NYU transplant program and the medical director of the kidney and pancreas program. And, one of the things that I think is most enjoyable about being a transplant nephrologist is getting people back to whatever their life they wanted before they ended up with kidney disease. And so, Mike, it's funny that you said I was getting personal. It's actually a standard question that I ask every, young woman that I see, whether for after transplant care or before transplant, because I do think a lot of people don't realize that you can go on and truly have a normal life in all ways after transplant. Pregnancy on dialysis is really tough and has not great outcomes. And so for someone trying to go through a pregnancy on dialysis, they have to do double the amount of dialysis that another person does. So they do dialysis 6 days a week.
Wow.
And longer sessions, so 6 days a week, at least for up to 5 hours a session. And even with that kind of dialysis, still the baby doesn't develop as well. And so many pregnancies on dialysis still result in either really early term pregnancies in the 20s of weeks of gestation with months in the ICU, or don't ever, unfortunately, actualize to having a real little baby to take home. But with transplant, that is a very different world. With transplantation, after waiting the appropriate time to make sure that you've gotten through the first year of transplant, not had rejections, and with the right medication adjustments, patients have normal pregnancies, go on to full-term pregnancies. Babies are delivered and don't always end up in the ICU. You really go home and be like whatever you would have been had kidney disease never crept into your life.
So, Dr. Ali, Samantha mentioned that you're a nephrologist.
Yes.
Yeah. So I have to be honest, until I donated my kidney, I had no idea what a nephrologist did. I had no idea what they were. I literally, I don't even know if I heard the word nephrologist prior to my kidney donation. So can you explain for the other Michael Lollos out there that don't know what a nephrologist is, what is a nephrologist?
So a nephrologist is a kidney disease specialist. Nephrologists do everything related to kidney disease, such as high blood pressure management, anything that causes, problems with the kidneys. So your kidneys are the organs that are responsible for cleaning your blood and making urine. And so we manage all of that. And then we've got a subset of nephrologists that do transplant nephrology, which is taking care of patients who have a kidney transplant or any other type of transplant.
Excellent. Thank you, because I'm sure there are other people who are listening that have no idea what a nephrologist is, like I didn't know back in 2018. Now I'm a little bit more versed in what a nephrologist is, but I appreciate the explanation.
So what was the state of transplantation about, 10, 15 years ago in terms of pregnancy when I was told what I was told that makes Mike cringe? Was that kind of the only option? Was it like, all right, adopt or bust back then?
I mean, there was much less data available about the success of pregnancies and how to really support someone through their transplant journey as well as their pregnancy journey. The main concern when we talk about pregnancy and transplant is that the immunosuppressant medications that we use commonly, Cellsapt or Myfortic, that medication is toxic during the developmental stages of the pregnancy. And so in the first trimester, when pregnancy is really developing and the fetus is developing, many birth defects develop at that point if someone gets pregnant on those medications. So in order to have a baby without the risk of birth defects, you have to come off that medication.
Oof.
And unfortunately, when you come off of that and onto the weaker immunosuppression, Imuran, which is also called azathioprine, you do risk rejection. And the collaborative data that was available in terms of how to do that conversion and how to support someone successfully and what everyone else was doing wasn't really all in one place. There is an organization that used to be called the National Pregnancy Registry. They are now called the Transplant Pregnancy Registry International. They were established originally in 1991 and then renamed in 2016. And they really collect the vast majority of data about patients who go on to have transplant, both men and women, um, all across all organs. So kidney, of course, being the largest organ, but liver, heart, lungs. What kind of immunosuppression patients were taking? What are the success rates? What's the rejection rate? Have people lost their kidney? Even some data now on IVF. And most recently, new immunosuppressions have been introduced to the market, in particular one called belatacept. And there's not very much data on the safety in pregnancy. However, they have the little data that's out there. And so this pregnancy registry becoming much more accessible over the last 10 years has helped all of transplantation be able to get educated themselves about how to help their patients through pregnancy successfully. And as we all collaborate and share our data with that registry, we continue to learn and improve our care.
So it's not that the transplant impacts your fertility, it's that the medications impact the safety of the transplant.
Correct. In fact, transplantation improves your fertility. So having kidney disease and the uremic toxins that build up in the body from kidney disease, these things called middle molecules that we don't really have a way to report on a lab, but a surrogate for that is the BUN, right? When people's BUNs are high because they're in kidney failure, they've got a lot of toxins building up. Those toxins actually suppress fertility. So for some young women, when they have kidney failure, they may lose their cycle. Their cycles become irregular. They may not ovulate on a regular cycle. And so fertility actually decreases with kidney disease in women. Transplantation clears you of all those toxins. And so for many young women, after their transplant, they get their cycle back for the first time. It may be irregular in the beginning, but then it gets regular. And so their fertility actually increases and improves. And that's why for the first year, we counsel people to really be attentive to contraceptive use. Because while a lot of patients come in thinking that their fertility is actually decreased, in fact, their fertility is increased.
Wow.
And so those first few months or a year after the transplant, you're actually quite fertile. And so we do recommend that for patients who are on Celsipin and mycophenolate, that not only do they use one, but actually use two forms of contraceptive. So one of those being a barrier contraceptive, and so condoms, and then one being, whatever other method you use, whether it's an IUD, birth control pills, birth control injections, patches, those sort of things. And that's to try to really prevent pregnancy while on mycophenolate agents.
So I'm assuming it's fair to say that if you're a female who has had a transplant, you should be consulting with your transplant team or nephrologist before you decide to attempt to have a family. Is that accurate?
Absolutely. So my recommendations are you wait till the 1 year mark. At the 1 year mark, that's when you've passed a year of immunosuppression without any rejection, without any recurrence of disease in the kidney. So for some people, they have a kidney disease that can recur in the transplant, such as FSGS or IgA or lupus. So you've gotten past that period. And then you've also, gotten to a stable point in terms of your immunosuppression needs, and you're further away from the rejection risk. Of course, the rejection risk is never zero, but you're now at a point where if you haven't had rejection for a year, you've been good with your medications, we can start this conversation. The other things that are predictive of success during a transplant pregnancy is having well-controlled blood pressure before starting the pregnancy, and then having little protein or no protein spilling into the urine. If you have more than 1 gram of protein in the urine, it indicates that there's already some sort of damage to the transplant kidney. And during a pregnancy, that can get worse.
Wow.
And then having a creatinine ideally less than 1.5, so that the best kidney function possible to go into the transplant. So those are sort of the parameters. More than a year from transplant, creatinine less than 1.5, well-controlled blood pressure, stable immunosuppression regimen, and no protein, or less than a gram of protein.
You mentioned before about people who are on dialysis and pregnant. How is that? Can you go into more detail on how that's handled? Because that's the first I never even thought about that someone could, a female could be on dialysis. Obviously, I know they could be on dialysis, but being on dialysis and then also being pregnant was not even something that came into my mind. So if you can expand on that, that's really interesting.
This is a very important topic because, it surprised me, Samantha, with you that as informed as you are and connected as you are to transplantation, that you didn't know that you could go on to have healthy, normal pregnancies. And it really took me time to kind of figure out why that was, and to realize that while I always talk to my young women about pregnancies and the success of pregnancies, that there may be patients out there who are told that pregnancies are not successful and that pregnancies are risky. And, in fact, when I joined NYU, even some of my colleagues who, of course, were not female, were saying that maybe pregnancy is a really risky thing. Now, as a team, we all have grown now to manage pregnancies. But it certainly is something that, there may be some misperceptions, and there's certainly hesitation. I think when someone doesn't have a lot of experience managing patients through pregnancies that are transplant candidates, because it is complicated. And I certainly tell my patients, we're getting pregnant together. It's going to be the three of us. We're going to be really close for the next 9 months.
But you're not sharing in the college costs, right?
No. I draw the line at college costs and at diapers. Diapers is second to
I was going to say,
college.
Samantha, that's a bargain. I'd put out a PSA if you're a patient, a transplant patient, you get pregnant at NYU, Dr. Ali shares in diaper changing and college costs.
No, I did my share of diaper changing, diaper buying, formula, sleepless nights, all of that. We are only together in this for the first 8 to 9 months.
That's funny.
Cannot wait. Well, it was funny because, I always went to my nephrology appointments. And the reason I was so lacking in knowledge was because I always went to my nephrology appointments with either my parents or at least my father. Because usually it was like, okay, somebody on our medical board is my nephrologist. And so it's like, it's not just my nephrology appointment. It's also, dad getting to see his buddy and talk about the latest medical board stuff or the latest swap failure stuff. And, it was never just my appointment. And with Dr. Ali, it was like, okay, Dad, I love you. Back off. This is my nephrologist now. I'm
out of the room.
You're not coming with me this time. It's just going to be the two of us. I'm in my mid-20s now. I think I was 25 when I first started seeing Dr. Ali, or 24. But
That's funny.
And, I was like, okay, well, now that I'm not completely and utterly embarrassed about asking about this sort of thing in front of my dad, I'm going to ask her because she brought it up.
Samantha, I think you've overcome that because now you're on a podcast talking about it. So you definitely
but he
not
doesn't know what
anymore.
podcasts are.
That's true. That's true. He's never going to listen to this.
No,
Dr.
not
Ali,
at
just
all.
you could say whatever you want. He will never listen to this.
Well, this part I'm going to ask Sebastian.
I haven't listened to a podcast myself. I'm working on it. It's on my list of things to learn. One of my younger surgeons he's my junior mentor, he says, because he teaches me the electronic things, like
funny.
how to make my phone work properly. And so I'll add this to his list to explain to me, how do I listen to podcasts?
Well, I think your first podcast should be One is Enough.
It will be.
Okay.
Agreed.
It's amazing the things that we don't think of from the patient perspective. The little things that you're told that end up changing all the decisions and all the pathways that you think, are open or end up being closed for you. So,
right.
I hope that this, gets to reach patients to know that pregnancy is an option. For Mike, you were asking about the success rate of pregnancies for patients who are on dialysis. And unfortunately, less than 30% of pregnancies on dialysis actually result in a successful live birth.
Wow.
That a lot of them end before 20 weeks of pregnancy, compared to transplant, where the success rate is almost 80%.
Wow.
And in
fantastic.
kidney transplant, it's even higher than that. So, transplantation really affords, with planning, the access to having healthy pregnancies, both for mom and for the baby.
Wow. Now, I don't, well, this is a pause here. Because I don't know when to interject on this. So, Samantha, I don't know if you have additional questions with this, but I'm going to segue into. Okay, I'm going to segue at some point. I have to segue into donors.
Yeah,
but
because that is a common question too.
Well, I don't
right?
even. So I don't. But you want to finish? Do we want to finish?
Yeah. So let's finish this bit, and then we'll go into the donor stuff, because the donor stuff is quick. I mean, the donor stuff's like wait a certain amount of time, and then you're fine. So from my understanding, it's like basically wait X amount of days, and then go have fun. Is from what my understanding is. But
so go ahead.
So one of the other things that I wanted to potentially discuss, and it goes back to the idea of your fertility being increased. So you said it doesn't impact your fertility, it impacts the health of the pregnancy. So in that case, is there a difference in success or necessary use of IVF?
IVF after transplant?
Yes.
So it depends on the type. So for patients who are doing IVF where they are going to carry the baby through the pregnancy, they do have to be off CellCept. And that's because, if you're carrying the fetus during that first and second trimester while organs are developing, that's when birth defects happen. We do keep patients off.
What kind of birth defects?
Good question. So a lot of them are facial defects that happen on CellCept. So cleft palate, eye socket and ear deformities, and jaw deformities.
Wow.
Okay.
So which is like where I'm like, my mind is going. You're saying that the patient or the recipient needs to be off these medicines, right? Off the immunosuppressive drugs, or on this other immunosuppressive drug that is a lesser dose, but that is causing probably damage to the kidney that they have, right? Because if you stop immunosuppressive drugs, that's a problem, right?
Right. So you can't stop the immunosuppression, you switch them out. So of all the immunosuppressions that patients are on, the one that causes a problem is CellCept or mycophenolate, which is also the other brand of it is Myfortic. So that's the one. Tacrolimus, cyclosporin, we think belatacept, prednisone, those are all okay.
Okay.
And those we don't touch. We continue those.
Okay.
The CellCept, which that class of medication is the one that has to be stopped.
Right.
That is switched to a medication called Imuran, which is also called azathioprine. And you continue that for about 2 months before attempting pregnancy.
That was my next question. So they need to be off that medicine for 2 months for it to get out of their system.
Exactly. So you allow it to wash out of the system, but also what you're doing in that time is giving the immune system time to decide if it's going to react against the kidney. So in that 2 months, you're watching the patient closely and watching their creatinine closely, so that if you end up having a rejection, you have the ability to pick up on that rejection before the pregnancy actually starts, and you can potentially reverse course, do kidney biopsies, treat rejection, and then unfortunately you're waiting another year before you try again, because once you have a rejection, you have to go back on CellCept. So the 2-month period between changing medication and then waiting to start attempting pregnancy is really a trial period for washing the medication out, and 2, seeing how your immune system decides to react. Then, once you're actually pregnant, the first trimester is pretty stable in terms of the immunosuppression. But in the beginning of the second trimester, the baby's liver actually starts to metabolize or chew up the tacrolimus or cyclosporin, whichever drug you're on, gets affected by the fetal liver. And so at that point, you need to monitor the immunosuppression levels very closely because tacrolimus, for example, can drop very low. And patients could have rejections during pregnancy, but it's not always easy to detect because naturally creatinine should go down during a pregnancy. And so in transplant patients, it simply may stay the same. It may just not go down. And so you know something is going on if the creatinine is the same or slightly going up. But unfortunately, at that point, you're in the middle of a pregnancy. And so your ability to treat rejection and sometimes even diagnose rejection is limited. So you really try to give some time before conception to try to allow the immune system to show you, is it going to start to act up or is it going to be okay with the dose of Imuran?
Wow.
And how, if something does come up, how early can you successfully have that child and then go on all of your immunosuppressants? Like what does post-birth look like, from that standpoint? Because obviously you have to go back on, but what about breastfeeding and all of that stuff?
Good question. So I work very closely with a high-risk OB team, and I would recommend that for any transplant patient who's pursuing pregnancy, that you need a transplant nephrologist and you need a high-risk maternal fetal medicine team that are coordinating and able to talk to each other very readily. And that's best in the same hospital, right?
Sure.
Because there will come a point where you're going to have to ask exactly that question. Not all pregnancies will make it to 40 weeks. In fact, most transplant pregnancies make it into the middle of the third trimester, but are delivered somewhere in that period. So after the baby's lungs have been developed and it's safe for a pregnancy, but still not at 40 weeks. So I tell my patients who are pregnant a couple things. One, plan the baby shower early. No baby showers should be after 30 weeks. They should all be before. So we have, time to get through the baby shower
like
before we have to worry
weeks,
about
that'll
anything.
Be fine. You're barely showing, but it'll be fine in the pictures.
And then, the follow-up is really intense. By the time you get to a year after transplant, you're probably down to doing once a month blood and you're back to your routines and working. But then during the pregnancy, in the second trimester, we go back to weekly blood work. And the weekly blood work is because we have to monitor the immunosuppression levels so closely. And we're also monitoring the urine to see if there's any protein developing in the urine. And then also monitoring your blood pressure to make sure your blood pressure isn't going up, because those are the early signs of something called preeclampsia, which may happen towards the end of the second, beginning of third trimester. If you develop preeclampsia, then between the transplant nephrologist and the high-risk OB team and yourself and your partner, we have to decide at what point do we hospitalize you to be monitored, at what point do we think the baby is well enough to be delivered in order to prevent any further complications with mom. Preeclampsia early on is simply a little bit of blood pressure going up, and we can control that with additional blood pressure medications. But when it progresses to more protein in the urine and then the creatinine going up and then the blood pressure being harder to control, then it goes into what we call eclampsia, which can then result in seizures.
Wow.
So we at that point really need to try to make sure that we are stopping the progression of this preeclampsia to eclampsia pathway. And so for many of my patients, they've been delivered about 34 and a half weeks. I had one patient who made it to 40 weeks.
Wow.
But most of my other patients, and I've had about 15 patients get pregnant and deliver successful, healthy babies.
Wow.
In what
awesome.
time span?
So in about the last 10 years that I've been practicing back in New York, I was in Jersey before that, which is a good number of pregnancies. It certainly keeps me stressed.
That's awesome.
That's fantastic.
But
and is bed rest a part of the equation, or
not necessarily? I mean, only if there is an issue in the pregnancy, which is probably not related to the transplant.
Okay.
Transplant is one piece, but pregnancies have their own list of complications and things that can happen, like how the placenta implants into the uterus that could end up with some complications. So if any of those type things happen, then the OB has to manage through those. And sometimes somebody might end up with bed rest for an obstetric issue. But
Mhm.
transplant wise, my patients have, all continued to work, continued to do what they're doing in their normal lives, but with a very strong commitment to doing blood work every week, seeing the high risk OB one week, seeing me the other week. We alternate, checking their blood pressure at home every day, letting us know if the swelling is getting worse or the blood pressure is getting, more uncontrolled, because those are all the early signs that something isn't going right. And then we need to come to the hospital right away and make sure that we can check out, labs and blood pressures and stabilize what we need to stabilize, and then make those decisions about delivery.
Mhm. So delivery, is there any, difference, or is it, is C-section better because of, kidney placement, or is there any concern
Um,
there?
Good question. So here at NYU, our OB team does coordinate C-sections to make sure a transplant surgeon is around, but in fact, it's not really needed. The kidney transplant is not in the same plane as the uterus.
Mhm.
We always have a transplant surgeon in the operating room or in the hospital. They're usually there, standing in the corner watching the C-section. They're not really needed, but it is more comfortable to have them there.
Okay.
Um, we've had one of my patients who had her kidney transplant was midline, so it was in the middle because it was like a repeat transplant. I think her third, and for that we really wanted our transplant surgeon there just in case anything happened. But they're in such different locations, and the OBs are so extremely skilled at sections. But not all patients have a C-section. Most of my patients actually go on to natural labor,
Okay.
and have been able to deliver, vaginally as would be usual.
Wow.
Interesting. And then once the baby is born, how does breastfeeding work and all of that?
Great question. So
I assume
the
you have to go back
data,
on your meds, right? So,
yeah, I mean, I tried to make this decision with the mom, because I think everyone sort of has a different preference in terms of breastfeeding versus going back on their medications. There is not a great body of literature about breastfeeding and the mycophenolate agents.
okay.
So there is some thought that the mycophenolate medication could get into the breast milk, and therefore you're feeding the baby some immunosuppression. But we don't have great data on that. And probably the patients who want to breastfeed may choose to stay off of Cellcept, stay off of Myfortic. But on the flip side, for some patients, they want to get back on their immunosuppression as soon as possible. What was really important was getting through the pregnancy,
Mhm.
and then preserving their kidney function and making sure we get back to where they need to be. And so some people do choose not to breastfeed and go back on their mycophenolate agents. I did have one of my patients in Jersey actually happened to be an OBGYN nurse. And so she
Oh,
had the most extensive review of breastfeeding literature and had the best experience. And she chose to breastfeed and go back on her mycophenolate.
oh,
And
interesting.
baby is
Okay.
just fine. And so, I think that's a body of literature that we need more data on and more information. But I talked to the patient about, risk, benefit, what we know, all the things that we don't know, and then make a decision together. And then, formula versus breastfeeding.
Yeah, apparently, or both. And then what about, and this is getting more into the lifestyle of a patient, but and you are not a patient, but so maybe you can speak to it as a clinician, but not necessarily as lived experience. But what about, those early months when you're, immunizing the child and, doing all of that? I mean, you're immunosuppressed yourself. What does that look like?
So I think, after the baby is born, it is really hectic. And moms are sort of naturally the ones to take on everything. However, they really need to rely on their partners and their family support system to help, because they also have to go back to taking care of themselves as well.
Mhm.
Eating well, hydrating. I remember those first few weeks getting home from the hospital. I had two pretty complicated pregnancies. Um, and so it is hectic, and trying to remember to eat and drink and take care of yourself while also taking care of the baby and changing diapers and not sleeping and trying to remember who you fed and did you feed yourself too
And
is
did you take
crazy,
your
right?
pills?
And then you have to add medications to that, right? Did you take your cells up to date? Did you take your tacrolimus? And so I encourage my patients to remember that they need to focus on them, and they need to be okay with taking help from the family and the spouses. And one thing I forgot to say in the beginning, when we meet the 1 year mark and a patient wants to pursue pregnancy, I actually set up an hour counseling session with them separate from the visit, where all we talk about is pregnancy. And we talk about pregnancy with them and whomever is going to be their support person or spouse.
Mhm.
Because I think it's important that their spouse also understand the process and what we're doing and the commitment that's needed to support my patient. And I've never had a single patient and spouse say, no, I'm not coming, or I'm coming alone. It's really a very informative session, and it gives an opportunity for everyone to ask questions about things that I don't even think about adding
Mhm.
as the clinician. And so that's first is, having a good support system and defining what that is. And not everyone does traditional pregnancies, but you have to have a support system, whether that's mom or auntie to help you. There's going to be someone there that you have to rely on. For the vaccination, so certain vaccines are live vaccines.
Right.
Um,
That's
and
kind of what I was
so,
getting at. So,
yeah, the live vaccines, we do recommend that the transplant immunosuppressed person tries to avoid changing diapers, and for about 3 weeks.
Wow.
so wait a minute. As a transplant patient mom, you have a legitimate excuse to make dad change the diapers. I
Yep,
just want
yep.
this in writing. Can I get this in writing somehow?
That's awesome. I love that.
This is
So
fantastic news for me.
the live virus from the vaccines is shed through the stool, the
Wow.
GI tract, and also through the nasal passages.
Oh my gosh.
It's
And
going to
and
be
they're
tough.
pooping and stuff's coming out of their nose
Yeah,
constantly, so that's not good.
exactly. I mean, the little ones aren't so sniffly, but they're definitely pooping. And
Yeah.
so you do have to be careful with the diaper changes. If they're sick, then certainly also trying to, now that we all wear masks, sometimes, wearing a mask is not so terrible if the baby is really close. It helps protect the baby from, germs. It helps protect you from germs as well. So certainly in those situations, you can wear a mask, but the biggest one is really trying to avoid diaper changes and making sure you ask the pediatrician, which is a live vaccine. Is there a non-live version that would be just as effective for your baby? And if not, then yes, you should vaccinate if that's in line with what you think. And I'm encourage vaccination, but with some precaution to mom or to
So
the immunosuppressed individual.
so a serious question. If your spouse is not around, is the precaution just a mask, or like, I'm really being serious? Should
Yeah,
you
the
change the
gloves.
baby with like gloves? Like, so what if you had to do it? What would be the best
You had to do
precautions?
it alone,
Yeah. If you
basically.
had to, yeah. I mean, a mask helps for the respiratory secretions, and for the
Okay,
diaper, gloves and then hand washing after
right,
definitely would keep you safe. But the first preference is have someone else change
of course.
it. Because moms don't get breaks for much.
That's the preference for me. Now we're really focusing on female patients here. Is there anything for the male patients? Is there any impact to sperm motility? Is there any impact to them during this? Besides, obviously, the post-transplantation or the post-birth, vaccines and whatnot.
Yes. So for men who are fathering children, the CellCept mycophenolate myfortic issue is not an issue.
Okay.
It is only in the fetal development. It is not a problem for sperm. So
Wow.
I've had some male patients tell me that they were told they have to come off. They do not need to come off. There is no birth defect issue. They can father pregnancies just fine from day one.
Wow.
Interesting.
There is a medication class called the mTOR inhibitors. So that's rapamune, sirolimus, everolimus. Those medications, that class can decrease sperm count and motility. And so for patients who are men and are trying to, create a pregnancy with their spouse, but are having problems, if they're on those medications, they should definitely have their sperm checked. It is reversible. When they come off of those medications, the sperm count does go back up and they're able to go through with natural pregnancies.
No, that's fantastic.
That is great information.
So switching gears a little bit, it's not as big of a piece of your life, Dr. Ali, but I know Mike has gotten some questions on this throughout his mentoring program days as a donor.
Yes.
What is involved with donation and pregnancy? So
Dr. Ali, one of the reasons why, of course, we got to always bring it back to the donor. That's where I go. And Samantha always goes to the patient. That's why we're such a great team.
Yeah, that's why we do this together. We have one patient, one donor. Everything turns out equal in the end.
But I just, when you start listening to podcasts, you will listen to the episode where we had Megan Morant, who is a WWE personality. And when she just recently donated, and she only had 2 questions for her nephrologist. And the 2 questions were, can I run marathons? Because she's a marathon runner. And the next question was, can I get pregnant after donation? And she said on the podcast that if her nephrologist said no, that she couldn't get pregnant, it would really give her pause. And, she would have had to figure, like, maybe she would have had a family first and then, decide to donate. So like Samantha said, I think it's, it's probably not as involved, if you will, as it is for a patient. That was I loved hearing all that. It was great information. So what about for a donor, female donor? Can she get pregnant?
Yes, so donors can definitely get pregnant. There's no impact on fertility. The one thing that we do counsel donors on is the risk of preeclampsia, which again is high blood pressure during the pregnancy, which is increased with just one kidney. It's not very high to begin with, but it's slightly increased from the general population. And so to try to minimize the risk of preeclampsia developing, we do advise patients to wait at least 6 months after donation, preferably a year, in order to get pregnant, because by that point, your now one kidney that's left will have accommodated for, and compensated for the loss of the other. So your kidney function has stabilized, your blood pressure has stabilized, all of the things. And so you're in a better state rather than adding stress to then a surgery that you just had a month ago. Now, full disclosure, I've had patients accidentally get pregnant 1 month after donating. Went on to have perfectly healthy, normal, no preeclampsia pregnancies, but it did stress me out a little.
It's not recommended.
Not recommended.
Don't stress your doctor out. That's the key there.
Did increase my blood pressure a little bit until 9 months later when she delivered and was healthy. So we do recommend some waiting time just to allow the body to recover from the donation and then have a healthy pregnancy going forward.
So and that's it. But that's the donor segment. We're done.
That's the donor
that simple.
Segment. Yeah,
wait 6 months to a year. Obviously, consult with your nephrologist and have your baby.
Yeah, I remind my patients that if they do get pregnant in the future at whatever point that is, give us a call so that we're aware. And then also to remind their OB that they have one kidney. Right. So that, blood pressure is being monitored and protein is being monitored a little bit more closely than if they were not a kidney donor, but have had no issues with any of the pregnancies. And it's important to know, though, that there is a slightly increased risk of preeclampsia, which is why you should be, really monitoring yourself during pregnancy.
And male donors?
No issue for male donors. They can just
keep on
do
trucking.
what they normally do.
Yeah, exactly. Yes.
Awesome.
Wow. This is a ton of great information.
Yeah, and this is why I was so excited about this, because this episode feels the most scientific of all of our recordings so far.
Sure.
I think it's really where I was hoping to take this podcast. I really hope Dr. Ali will come back because she is a specialist in like 1,000 other things and 1,000 other trials. And NYU is always on the cutting edge. So I hope we can have her back. But
I think that she will be invited again and gladly accept.
Absolutely.
Right, Dr. Ali?
Absolutely. I'm here for
Not
whatever
to put you on the
need.
spot, but
No, I love this. And I appreciate you doing this because I think you're reaching an audience that we don't always reach in our visits, and spreading, very valuable information about transplantation, which sometimes we don't always think of talking about some of these topics. And so I applaud what you're doing, and I'm definitely supportive. And whatever you need from me, I'm here.
Samantha, we got that on tape.
yes, we did.
Except for
And I
flying
will be
lessons.
using that in my visits to her. But yeah, this is, like I said, this is what I really wanted to get out of this podcast because, part of it was to normalize the conversation around donation and transplantation. But the other half of it is also getting the correct information out there
Yes.
and dispelling the myths and beliefs of yesteryear and, the wrong facts of, Google Doctor and all of that stuff. Because we at the NKR are really very fortunate in that we work with the, over 100 of the top transplant centers in the country. And we have great relationships with them, thank God.
Sure.
And we have access to all of these experts who know this stuff, but aren't
Right.
necessarily in the public domain getting asked these questions. So
Dr. Ali is probably not going to say anything when I say what I'm about to say, but she said something earlier that stuck with me. You mentioned, Samantha, that we are partners with slightly over 100 transplant centers, but there's over 250 transplant centers in the United States, and I think every transplant center has excellent intentions, but I do think, in my experience, that depending on what transplant center you go to, you may get, advice. You may get certain advice. My personal feeling, I don't know about Dr. Ali if she'll comment. I always say to donors or even to patients, get a second opinion.
Yes.
If something is not, something doesn't feel right, if you're not sure about that answer, go to a different transplant center, go to a different nephrologist and see, Samantha is a great example. She was given some information. I know it was a long time ago and the information was different, but she was given information, and that is sort of contradictory to what we've learned today. So
it's completely contradictory. It said you cannot have children. We just learned we can.
I was trying to be nice, Samantha. I was trying to be
Listen,
nice.
Like I said, it was 16 years ago. The field was much different. I mean, non-steroidal immunosuppressant protocols were like just entering the market. So it was a completely different show. It's completely different scene medication wise. It makes sense that was the information back then, but the fact is that information changes. And that's, again, one of the reasons that we have this podcast is to, send that information out there and do it in a timely manner.
I'm happy there are many Dr. Ali's in the world. We have the best Dr. Ali here on the podcast today, but there are excellent nephrologists and excellent transplant teams throughout the United States. And like I said, I strongly encourage people to, seek other advice if, they're not getting the answer that they, or they're not getting an answer at all, at the center that they're at.
Absolutely. So before we close this out, first of all, I just want to thank Dr. Ali again so much for not only being a wonderful nephrologist for me, but also for joining us tonight on this podcast, and to NYU for, again, being a wonderful transplant center to me, but also being a great transplant center, a great friend to the NKR, and letting her join us on this podcast. We cannot, do this without great partners like NYU.
Absolutely.
Dr. Ali, is there anything you want to add to the transplant community at large before we close this down?
Well, thank you so much for having me. And I think, think of transplantation as getting back to the life that you wanted if you'd never had kidney disease. And if there's a question that you have or something that seems to be a barrier, like Mike said, ask another question, ask another opinion, and see if, we can get you back to where we wanted you to be.
You could learn more about the podcast by visiting kidneyregistry.org/one. When you're there, you can sign up to be on our email list so that you'll be the first to know when we drop a new episode. And trust me, you want to be the first to know.